We'll go ahead and get started. It's 1:35. So,
Yep.
uh,
Yeah, we got a lot of information to go through.
yeah, this is for those of you that are just joining in. We are talking about Medicare waste, fraud, and abuse. Don, thank you. I'm rooting for the Lions. I wish they would have beat the 49ers, Don. Unfortunately, they didn't, and we had to watch this 49ers Chiefs Super Bowl. But all good. Maybe next year. But
Yep.
anyways, for those of you that are just tuning in, we've been talking about MACRA and MIPS. Today's going to be sort of a part two of that discussion. And before we get started, I do want to do our traditional, we do a weekly trivia. And this is regarding last week's topic. I'm going to go ahead and share screen with you guys. And Jose, let me know if you can see, make sure we're not having any technical difficulties.
Got it.
So this is a question to the audience. You can put your answers in chat. What year was the Medicare Access and Chip Reauthorization Act, MACRA, passed? Was it A, 2008, B, 2010, C, 2015, or D, 2018? Now, again, you guys can put your answers in chat. We'll give you about a minute to do so. Don't be shy. Don says B. Juana says C.
It's too late now.
Can't make any promises, Don. We'll give it another 30 seconds. So I know we got some more participants in here. Please don't be shy. Throw your answer in. If it was for $1 million, would you put an answer in? All right, all right. So we got two answers, and that's good enough. So we got a B and a C. So again, the question was, what year was the Medicare Access and Chip Reauthorization Act passed? The answer is, in fact, C, 2015. Don, it's
So
okay.
Don, you're probably either thinking of when all of the meaningful use incentives from the PPACA started really taking into effect, which was 2010, or honestly, because they passed so close together within the same presidential administration, you probably just mix them up as part one and part two, which is absolutely how it came out for the healthcare administrative side of things. So it's a completely natural a difference without a distinction, right? So cool.
All
So
good.
let's
So
punch it, right? So much to go through.
yes, we got a lot to cover today, so we'll keep the introduction. We'll try to keep it brief, but good afternoon, good morning, good evening, wherever you're, wherever you guys are located. My name is Ray Walters. I'm with EPICompliance, and happy to have everybody on this webinar today. As mentioned, we're going to be sort of diving in a little further into the Medicare waste, fraud, and abuse MACRA MIPS part two. I am joined today by my special guest, Jose Delgado.
How's it
Again,
going? How's it going?
glad to have you on, Jose. And again, Jose is a healthcare professional with over 17 years of experience. His latest venture is owning a telehealth practice. And I didn't mention this as well, but he does dabble in some healthcare consulting as well. Jose, anything you'd like to add to that?
No, honestly, we've got the mental health practice that we basically use as a test bed for all the things that we tell our consulting clients to do. And we show it as a proof of concept of, hey, look, these are the things we're telling you to do. This is why we're telling you to do it. So fun stuff.
Awesome, awesome. And just a brief background, again, those of you that are joining, just joining us for the first time today. We are EPICompliance. We're established in 2013 by leading healthcare professionals. Our goal is simple. We want to help healthcare organizations, healthcare students, and business associates stay compliant with HIPAA privacy, HIPAA security, OSHA for healthcare, Medicare waste, fraud, and abuse. We also founded EPI conferences. um, which is an in-person event currently. And one of the trainings that we provide at this event is is a certified HIPAA security officer training program. Jose was an instructor for this program, but this is a very comprehensive training for what did you say, Jose? Office managers, compliance officers, business owners, wanting a little more deeper understanding of HIPAA, because let's face it, there's a lot that goes into it. And
Anyone who is dealing with compliance on a regular basis and is incentivized on keeping track of it, that's your person. That's what you want to, that's the
yes,
person that wants to be on that boot camp. We do everything we can to make the information that is super dry relatable to you, and what we do is we sprinkle in also cases that are currently working through the courts or working through the news when we come upon things that you should and things you definitely should not do.
no, absolutely. And to add to that, this is a training that we're actually going to be offering online here very soon. Um, I said this last week, but we're really pushing to have this out before the end of first quarter. So stay tuned on that. You guys will receive some correspondence once we get a more solidified date. But like I said, you'll be able to take this course online moving forward. Um, Stay tuned. We'll be sending you some more information on that. So let's dive into today's objectives. Uh, Jose, I want to provide just a brief recap from last week's presentation. Obviously, talk about today's performance categories and expound a little bit on the scoring metrics behind the MACRA MIPS. Um,
Yeah, so the TLDR of last week is we went through the history of how we got to MACRA and MIPS and why MACRA and MIPS is designed the way that it is. Today we're going to be going over a lot of the well, not a lot, but some of the metrics and figuring out as we go through what's the best way to go about playing this game of federal monopoly if we want to play at all. Before we even jump right into MIPS categories themselves, there's also the possibility of bypassing MIPS by participating in the advanced payment models, right? But to do that, you have to be a very specific kind of provider in a very specific type of practice. So basically, what the entire incentive program for the AAPMs is for Medicare to stop spending as much money on Medicare patients and pushing the risk onto the provider pool. So basically, you're going back to the early 90s where it's a capitated contract. They're going to pay you a flat fee per month and you deal with all the nonsense. Whether they're healthy, great, you make a lot of money. If they're sick, your job is to get them as healthy as possible, as quickly as possible. This is where all the HMOs came into play because it was easier to control the patients and where they went and how much they spent on care. What they did with the AAPMs and MIPS, though, was they added quality measures, but realistically, what they're looking at is the same crap as always. How do we keep them out of the institutions that are extremely expensive? So if you're billing a facility code, we're talking about you, your ALFs, your nursing homes, your hospice, your hospitals. The federal government wants to keep the patients out of there because they realize that since 2008, since they had all the information from the PPACA and the meaningful use EHRs, they could figure out how often people were going and what were the outcomes long term and short term. Now, this would be something like if you're part of an ACO, if you're part of certain teaching institutions, there's a whole list of them. For most people, AAPMs don't matter. Keep an eye on them. There can be a good use of them if you have a good patient population. If you have a healthy Medicare patient population and you're seeing them once, maybe twice a year, then you'll be approached by an ACO. You'll be approached by an organization that wants to bring your patients into the fold because you're keeping them healthy. If not, then you got to find other ways to play with it, right? And this is where MIPS comes into play for everybody else that wants to participate in this program, where you're again playing by the federal government's rules in the hope that you're going to get a percentage increase on what you put out. Now, this is a 0 to 100 point scale, but not everything is worth 25%.
right, right.
it's a bloody mess of mathematics and arithmetic. And realistically, you want to kind of pick and choose what's most important so that way you can hit the goals that you want. Some of these things the EHRs will track on their own, and you just have to attest to it. Some of it because they've fixed some of the issues they had with the EHRs and meaningful use. Um, some of it you still need to track on your own and show proof of, but we'll go over a few of those things today, you know. So when we go on to the next one, Ray. So this
This
is
is
what
a
I'm talking about
yeah,
here.
this is a breakdown of the scoring.
This bloody mess. So when I'm looking at making my providers do something, right? Because they're the ones seeing the patient. We're really looking at the quality measures on there. And this is where the dreaded customer surveys come into play. This goes into what kind of
Patient satisfaction.
what's the bedside manner like, you know, and there's a lot of different things that you can do in a practice to jump these scores up. But realistically, we want to take a look at what are the most important things on those groups. We're not going to dive into them specifically, but I want you to know if you look at this, if I have to pick a category or two categories to focus what I'm doing, it's going to be on quality and the advancing care information.
Absolutely.
If I have to ignore something, it's the cost. But realistically, CMS is going to be putting all that all together for you. So
Exactly.
that 10% is completely taken off your table. So it allows for us to kind of look at, okay, let me document the practice improvement activities just as we go and incorporate technology. And, you know, then I can hit as many of the points as I can from there, right? So when we're looking at some of these things, we're looking at some of these measures, we're looking at things like, hey, when I do the physical or when I do an evaluation, am I hitting certain metrics, you know? So am I asking them, hey, are you depressed? This is where the PHQ-9 comes into play. Hey, do they have a history of melanoma? For Juana, you mentioned dermatology. You know, this is where you ask if they've had a cancer screening of some kind, if they have melanoma, if they have anything that you want they feel like you need to take a look at. So one of them would be preventative screening for tobacco use. That's on everybody. If you need to do a biopsy, high blood pressure, you know, so there's a lot of basic things that when you're doing an eval, you're going to want to go through just because you're doing an eval slash physical. So we would just want to document that we ask those things. Now, in some cases, it doesn't make any sense. Why am I asking if this patient smokes or not, or why do I care? Well, Medicare cares. Remember that MIPS, MACRA, meaningful use, all of those care measures that were in meaningful use, they weren't designed for the specialist. Because I'll be perfectly honest, the federal government doesn't understand healthcare, much less specialists. They base everything off of primary care and hope they get some of it right. And don't worry,
Right.
hopefully that's what the AMA and AHA are there for, is to complain when they get things wrong. And they're constantly complaining if you keep track of if you keep track of those two organizations. So you really just want to make sure that your providers are documenting. It may take a couple of extra seconds, and there may be ways to expedite this process. So, for example, like in our mental health office, I don't care if you smoke. I mean, I care, but it doesn't really help me make any clinical decisions in my practice whether you smoke or not, because it doesn't really affect what we do. COPD might, you know, cancer might, but the act of just smoking doesn't matter to me. But we put it in our initial patient paperwork so that way the patient checks it, and then we just confirm it when we're bringing them into the exam room. Boom, we're done with that piece. So there's ways to do this to where we don't change how our providers like to practice medicine, because it's as much an art as it is a science. Yeah, absolutely. I mean, yeah, so I don't take blood pressure in my office in mental health either, Juana. But a lot of people wear smartwatches.
Yep.
So we can gather the measure from the smartwatch if we're doing telemedicine. Yep. But if not, for the evaluations for mental health, anyways, if they want a class 2 drug, well, I got to bring them in the office for the eval. So that may be something that you want to do and establish, so that way you can continue, because as long as you grab it once, you're good to go. Now, Let's keep going to the next one though, Ray.
Yeah, so let's sort of elaborate on these quality or performance categories. So, Jose, could you elaborate just the obviously it was mentioned there are six sort of collection types that they base off that score.
Yeah.
If you could sort of run through this and in terms of what these mean and how they score these things.
Yeah, so basically a lot of these are going to be currently tracked on their own, right? So the Medicare Part B claim measures,
Hmm.
if it's on the claim, then they're going to get it. Now, the trick of this is it's still got to be electronic. So if you're on paper still submitting a CMS 1500 form, if you don't know what that is, don't put a one in the chat because it's going to make me feel old now. All right, everybody. But if you're filling out those CMS 1500 forms and mailing them in, then none of that matters. It's not going to be counted. It's got to be sent through the EHR. It's got to be sent through an approved EHR because there were, especially in 08, 09, I don't know if everybody remembers, every IT company in the world had an EHR, but that's why they went through the process of credentialing the EHRs. So if you're using one of the major EHRs, you're set up, you're fine. Some of the smaller ones have been able to get credentialed as well now for MACRA and MIPS, so you're okay. But again, the Medicare Part B claims parts, that's going to be submitted electronically as you submit a claim. The electronic quality measures, that's going to be submitted electronically through the EHR. The consumer assessment, that one is all on the patients. So when it comes to Medicare patients, there are certain things that we've found as a consulting firm and as an owner of a practice that automatically kicks you in the teeth on this. One, if they're waiting more than 30 minutes for their appointment, it's going to hurt you on that survey. That's step one. Step two, if the not the MA, but if the front desk person is not in a good mood and nice, that's going to kick you in the teeth on your survey. And the third one, the third common issue is if the provider is deemed to not be listening to the concerns of the patient. Those three things are the quickest things to kick you in the teeth on these patient surveys. Everything else you can kind of play with, and everybody's going to be a little bit different. And there's going to be quite a few Medicare patients that don't even bother to do the survey. But what you want to do is incentivize, and incentivize is the wrong word. Lawyer's going to kick my teeth for that one. But but you want to go and say, just like you're saying, hey, if you had a great, yeah, that's the consumer assessment. That's the bottom one that Ray has the hyperlink to. You want to go and just the same kind of people that you would ask to give you a Google review, you want to ask them to do the survey.
I was gonna say you probably want to pick and choose you want
If
to.
possible, you want to,
Yeah,
but
yeah,
there are certain specialties that it doesn't matter because an unhappy customer is going to be the louder customer than the happy customer, right? Like it's just kind of how it goes. And there's only so much that you could do to address the fact. And then do you really want to address it or is it just going to make it worse, right?
yeah.
So
Right.
those kinds of things we kind of want to just understand that they're happening outside of our as administrators realm of control. One of the things that we can do though is make sure that everybody has access and knows what is expected of them. So for the providers, like we were talking about before, let's knock some of these out before the provider even comes in. So that way they don't have to get thrown off the rhythm they've been doing for the last 5 years since they started med school, right? So it's kind of it's take a look, pick and choose, and you can kind of go from there. If you're in any specialty specific, your lobbying arm is going to have a list of the measures that are going to be easiest for you to handle so you can meet these MIPS measures. So you definitely want to leverage that uh, because they're there to help you. That's what they're there for. So let's go to the next one, Ray. All
So
right, so resource use performance. So this is one where the federal government is trying to get patients to become more tech literate And COVID actually really helped us out with this. I don't know if you were doing no telemedicine and you wanted to do telemedicine, COVID was the best thing to happen to you because it became a point to where the patients were like, they even told us we wanted to implement telemedicine heavily in our practice. And pre-COVID, so late Q4 2019, we were at 10% maybe on telemedicine visits.
Huh.
As soon as March of 2020 came around, that flipped on its head. And we were literally 100% because it was in the middle of COVID. But even after COVID, it's decreased because we've had to obviously follow all the regulations going back to a normal. But we're still at an 85-88% telemedicine across all
That's great.
payers.
Yeah.
So, I mean, it's really a matter of how do we keep track of those performance metrics? One of those things is the patient portal. What access does the patient have on the patient portal? Do they have access to just scheduling? Do they have access to their record? If you're in a super sensitive specialty, talking to you infectious disease, my infectious disease brothers and mental health brothers, we've got to go and make sure that we're not putting all of the information in that patient portal that can be deemed as super sensitive or super confidential. We can hold those because of if the provider deems that it's a harm, potential harm to the patient, right? So we want to make sure that we're aware of what those rules are. But by and large, using the patient portal properly and making sure the patients know how to do it, it can really decrease the amount of phone calls that are influxing your front office, your bullpen, if you will, from patient scheduling to even using that same patient portal for again those, all right, I need to grab my records, or my son or daughter needs to grab my records, so that way I can go down and visit them for 3 months, or whatever the case may be. It makes some of the processes in the bullpen a little bit easier and a little more manageable.
Is that something that practice is keeping track of, or is that something that CMS is keeping track of in terms of?
So yeah, every EHR, every account and every EHR, you have to turn on the patient portal. For a while there, some
Gotcha.
of the EHRs were charging you extra for the patient portal, but now, from what I understand, all the major EHRs, the patient portal is free. It depends on what kind of information you have through there that they have access to, whether the patient can upload information or just download information, request visits, things of that nature, correspond with the provider directly through the patient portal.
Sure.
So this can really help out your bullpen, help out your operations. What it does is it allows, if you know how to schedule in a very effective manner, you can block out time, 20 minutes in the afternoon, 20 minutes in the morning, for a provider just hit all their messages all in one go. Because once you've been in a specialty for about 6-7 months, 80% of the questions,
Right.
right? And across all specialties, one of them is, I didn't get my meds, or it didn't go to the pharmacist correctly. That's always the same crap. So you just want to make sure, find out what your FAQs are, and then boom, punch it from there. Um, let's go to the next one. Ooh, we're running behind, but I want to make sure we hit those
So
AAPMs
let's
first to
talk
start.
about
All
the
right.
practice improvement activity measures.
Yeah. So when we talk about practice improvement, this is where we're starting to coordinate with other specialties as well, right? So if I'm working with another practice that does CCM, chronic care management, if I'm working with a nursing home, if I'm working with a bunch of specialists, remember, this is designed from the aspect of a GP working with Medicare patients, not your, like Ray and I in our 30s, right? You're talking about someone who's 65 plus. So when you do that, you're looking at, most of the time, you're looking at multiple conditions across multiple specialties. I may have a patient, a 65-year-old patient, that he is seeing me for general. He's got a cardiologist. He's got an ortho because he got hurt chasing his dog, you know. And then on top of that, we may have a rheumatologist or an oncologist from an old cancer issue. We may have some mental health issues because he can't move around as much, or something happened to the dog that he tripped over. Like there's a lot of different factors here that care coordination really needs to come into play. And honestly, there should be more, in my opinion, there should be more coordination across the specialties when we're dealing with cases. It should be
Sure.
easier for us, because what we don't want is for us to all share the liability to, for example, put a patient on a medication cocktail, and then all of a sudden we're all pointing fingers and the lawyers are picking the last one who picked the most recent script. It's your fault. It's not effective. It's not the way to do things. Like, we really should be more effective and more collaborative. Now, that is a very different than the pervasive thought process and methodology for healthcare in the US. But I think that is something that the next generation, especially, is something that they can understand, because they're not looking at living life as an entrepreneur. Anyways, most of the guys coming out of med school want to be employees. So forget it. We can control their schedule then as administrators, right? So they're not
Yeah.
our bosses anymore. They're our employees. They are below us. So it really changes the dynamic as well, and making them more compliant with different incentives and initiatives. When we look at the emergency preparedness stuff, this is where we can really talk to them about, hey, hurricane's coming. We're closed this day or we're closed that day. Or for a PT clinic or an OT clinic, hey, our office got flooded from the hurricane, so we're renting out space in X and X hotel down the road. So come to the meeting room, come to the conference room there. So that way we
Right.
can keep our business flow going and not kill our practice. So there's a lot of different ways that we can do the clinical improvement. We just got to take a look at what's the most effective ones. And remember, once you pick a category, stay that category across all boards, because then you can build the process and you won't get as much pushback. A lot of this stuff, though, we're already doing. If you
That's
look at what the measures are, it's just a matter of documenting it properly in the right place, and you're good to go. You know what I mean? Like, it just makes sense. When it comes to health equity, I'm not even going to touch that one, just because it's equity is a ridiculous word for this stuff. So let's participation in an APM again. When it comes to APMs, you want to go and take a look at what's my percentage, right? So if I'm a qualifying provider for the AAPM, I only need 35% of my Medicare population to be part of that AAPM, and the rest can be part of Medicare standard, Medicare Part B standard, right? So you can play with the ACO and not the ACO, and then you can play by yourself. So you can kind of balance and seesaw and see what's the best way to do it without throwing all your eggs in one basket. Because I'll be honest with you, I haven't found an ACO that is profitable and effective after year 3. They usually crash out around year 3, year 4, because they've saved all the money they can save. So now they got to kill all the profits. And as soon as you start touching profits, everybody starts dissolving. It's just how it goes.
interesting.
The ACO model we have not found one that is truly viable long term. Cool, let's go.
Good point.
So, all right. Advanced care information. This is some of the
best for
stuff that we've
last.
been talking about. Again, a lot of these EHRs are going to be submitting data for you, which is a good thing and a bad thing. This is where you really want to take a look at your population and your specialty. And, one of the slides down the road is going to show the payment incentive, which
Yes.
is far more,
It's next slide, actually.
okay, it's far more linear than one would want. So again, take a look at your patient population, take a look at if the juice is worth the squeeze. in some cases, in some specialties, it's not worth it. It's not worth the documentation. And especially if you don't participate in a high amount of Medicare patients, you may not care. So take a look at your patient population, take a look at your desired patient population. It may not be worth it for you to do all this extra stuff or keep track of all this extra stuff, and you take the hit, like, but you've got to play. If you're going to play smart. If you're not going to play, don't play at all, don't even bother, right? So you want to kind of just take a look at all these measures. And you're going to want to deep dive certain sections. This is the one that you don't need to deep dive as much, but again, you're going to be able to you're going to really be able to track it. The EHR is going to be able to track it for you, and you just got to figure out what specialty matters for this stuff. So right now, mental health is a big one, and then obviously keeping track of the pharmaceuticals list that the patient is on. That's one that you really want to keep track of that. So, cool.
Good information. This is the incentive
Yeah.
chart.
So, yeah, I mean, absolutely want to. And in dermatology, you're going to do a ton of Medicare, especially depending on where you are, right? So it's just it's so if that's the case, you're looking at is it worth it? You know what I mean? Like, it's going to go up to 1/4%, or it's going to total. I think it's going to total at 9%, but
9% is what I read.
that's all fudgy, right? That's what they say the adjustment is. But if they lower the overall fee schedule, then you may be still underwater, because if they lower the fee schedule by 10%, which, depending on what news outlet you hear, there's between a 5% and a 40% decrease in in the Medicare payout starting as early as next year. If they reduce it by 10% and they give you a 9% adjustment bonus, you're still losing 1%. So does that mathematics work for you? Does that arithmetic work for you? Every practice is going to be different. There are certain specialties that this just doesn't make sense at all. If I'm a PT clinic, I'll be flat out with you. If I'm a PT clinic, screw MIPS. It's not worth it. It's absolutely not worth it, especially considering the fact that PTs have been getting hosed with the bundle payments before any of the surgeons did back in 2009. So really take a look at how you're getting paid, what you're getting paid, and is it worth to ask and track all of this information? If it's not worth it, don't bother. Just make sure you're not attesting to anything, because that's where they'll get you. If you attest to something and you didn't do it, you're just waiting for them to come get you. All right. So just make sure you look at what the rules are. Take a sit down with the executive team of your practice and say, look, these are the measures. This is how we're doing. We have to change A, B, C, and D to hit this. Is it worth it? So,
And focus
yeah,
on the right categories as well. Obviously,
yeah, absolutely. I mean, and you want to focus your time on the correct categories, right? Like, so obviously the clinical side is going to be the part that matters the most, which is, where you start asking those questions about cancer screenings, your testing screenings. This is where the Medicare patients start getting pissed off, because they're getting all these questionnaires, all these tests done, every single provider. And if, like, my grandparents, my grandmother has a rheumatologist, a pain management doctor, a GP, an ortho, and then my grandfather has the cardiologist, the GP, the ortho. So you want to take a look at, like, that's 7 different practices. They're asking the same questions.
yeah, yeah.
You know what I mean? Like, how often are you going to fill out a PHQ-9 and be like, Jesus, just tell me I'm depressed already? You made me fill it out of my GP, my counseling office, and then my cardiologist. All right, I guess I'm depressed, guys. Just leave me alone. Do I have to fill this out again? I guess that's where I would be, and I'm 36.
Mm.
You know what I mean? Like, I can only imagine what my grandparents are saying. All right. My grandmother's probably a little more colorful and in Spanish, but that's a whole nother bag of tricks. So just really take a look at it all. Right. So on to the next one.
I think that concludes.
Perfect,
Yeah,
perfect. Yeah, so
that
yeah,
concludes
so
this
we finished
topic.
kind of right on time here
Yeah,
for what we were shooting at. Um, Go ahead, Ray. I'm
I
sorry.
was gonna say what we can do is we'll dive into at the end of the presentation. We usually do a quick Q&A. So anybody that's got questions, go ahead and throw them in chat, and Jose and myself will be able to answer those. I know Juana had one. Let me scroll up real fast. Where did it go? So we have a patient portal and we do telemedicine. How does this apply to performance measure? How does CMS know we do have these things or those things?
So uh the EHR automatically is going to send some of that stuff. Also, in your EHR, there should be an attestation dashboard, and then you can look and see how you're doing for the reporting period. And you can see what needs to be fixed. Each EHR is going to be slightly different, so it's hard for me to tell. And especially if you go specialist specific, I'm not going to know every single cardiology, dermatology, ortho platform there is. But if you're at one of the big boys, Athena, eClinical, Practice Fusion,
Mhm.
Allscripts, they all have a MACRA MIPS dashboard. And on that dashboard, it can show you the things that you need to do or the things that you're doing well in. And then you can go in and track specifically for you.
Is it better to take the penalties versus doing MIPS? That was
The
also
answer to that question absolutely is it depends. In my mental health practice, in my so again, in my mental health practice, I don't want to play the game. So we don't. We I'm unconcerned about it. We use Practice Fusion. They send in what they send in. We get the score that we get. I am unconcerned about the decrease in revenue on my Medicare side because I'm increasing the volume of patients and the type of patients that we want. So how can I put this?
so it's a win for you.
Well, so it's an irrelevance.
Let
I'm not going to concern myself
right, right.
about something that's not going to that doesn't matter as much. Currently, our payer mix, which you want to know your payer mix because that's going to tell you what you need to focus on, right? Our payer mix is considered healthy for Northeast Florida because we're
Mhm.
30% Medicare, 30% Blue Cross, and then cash and smaller and other insurances is my other 40%. What we're doing is we're actually working with companies that would apply for the AAPMs, so that way we can build a direct pay contract. They can get their points for care coordination, and we bill them directly for our services.
Yeah.
I don't want to play the game. They can report whatever information they want. I'm more than happy to provide it for them. They can handle that shit. I want to work with companies that are self-insured. Why? Because if they're self-insured, they control what measures they're working with. Now, granted, if you're self-insured, you're more likely not to be a Medicare patient. So for me, it's a double win there because I'm again circumventing the macro MIPS conversation. There are things that make sense within macro and MIPS. It's not to say that macro and MIPS is all bad. You want to just take a look and see if it makes sense for you. If you're in that 40% population and it's going to be a sustained or increasing population, then you may need to adjust the way you do business to make sure you meet those measures. It just makes numbers sense there. But then you can be smarter in other ways and perhaps move your schedule around some and or focus on certain areas and really specialize your staff to dealing with a certain type of patient. Alternatively, bring in other subspecialties or other services within your practice so you can leverage the same your same fixed and variable cost with another provider or another specialty that brings in more foot traffic and more revenue so it spreads the costs around. So if you're the if you're the practice that owns the building, but maybe your provider is at a nursing home 2 days a week or 2 mornings a week, well, maybe we're renting out those rooms to a specialist or to, another provider even. So you really want to be able to stretch your costs out over another provider, and then it may not matter. So it's just about being clever with the resources that you have, because nobody has infinite resources. That's just not a thing.
Juana's got a lot of experience in the dermatology industry. Says
What
worked for
Go
another
for it.
dermatology group for 20 years and never wanted to do meaningful use. That is now MIPS. He always said he
Yeah.
better pay the penalties than he'd rather pay the penalties than spending money and time on trying to meet all these measurements.
Absolutely. So meaningful use was a giant pain in the butt. We talked about it last week, where there were times when you'd have to
Don't blame
screenshot
him.
when you were attesting to make sure you met the measurement, because if not, then you were attesting and it was fraudulent because the PPACA assumed you were a criminal. So it was absolutely, it was not worth the carrot that they were telling you, the bonus that they were trying to sell us. It just didn't make any sense. Now I even know, like I said, I know providers that have said, screw it. I'm I'm done with the EHRs. I'm only going to use an EHR to send in my bill electronically because I get paid faster. But if it wasn't for that, I know providers that will go completely back to paper and give the proverbial middle finger to CMS. It just depends, how long are we looking to practice for? If your provider is close to Medicare aged and they are not looking to sell, so this business will die with them, there's no point. Don't bother.
Good
It's too
point.
much paperwork.
Yeah.
If your provider is looking for a legacy, a payout, a legacy, something along those lines, then you've got to figure out how to boil that frog.
Mm.
Pardon the phrase.
Boil that
Just
frog. Never heard that one, Jose.
You've never heard of that? So when you're cooking frog, you don't throw them into steaming hot water, right? You put them in the water and then you turn up the heat slowly.
There you go. I
So it's
like
a
that.
it's a hot tub until it's not, right? So
Yeah. Yeah.
it's absolutely something where you just got to take a look at what we're trying to do as an organization. What's our goal? But this is where your executive team, your management team, your compliance team, and your business plan all have to meet in the same place. If they're all moving in different directions, which you see all the time in hospitals, insurance
Mhm.
companies, even health IT companies, private equity companies, now you're not going to be able to stay aligned as an organization. All of these departments have to work together. So I normally would say, what is the business plan look like? Then figure out your compliance issues around that.
No, good
That's
point.
normally the way I would do it. Because if you don't have any money, none of it matters. You're not going to be in business. It's just kind of how it goes. Either that or you've got a sugar daddy and grant money. But then usually if you're doing that stuff, none of this stuff matters anyways, because the rules are skewed in your favor. Like, hey, I can be in a rural area, get a Medicaid contract. So now all of a sudden, Medicaid is paying me as much as Medicare. And Ray, just for you and
Never
I,
seen
because
that
we're in
happen.
Northeast Florida,
Yeah.
Medicaid, rural area is Orange Park.
Really?
Look
That's
around
it.
Orange Park.
That's interesting.
Yeah, oh yeah. Because remember, it's all state based.
I would have thought more of Middleburg.
Absolutely. Middleburg's, yeah, absolutely. There's more cows than people in Middleburg. But what I mean, you don't have to be that far. Honestly, half of St. Johns County is
How do
considered
they
rural.
define that? How do they
It's
define that? Is
based
it
on
population?
population.
Okay.
It's based on population per square mile
Mhm.
and how many providers are within the said square mile.
Well, that makes sense now,
Yeah.
but
No, definitely. Well,
huh.
Ray's gonna send you this stuff with our contact information. So if there's any other questions you got, please feel free. We're about that time anyways. We're
Yep.
all gonna turn into pumpkins. So
Juan, I appreciate your
I'm
time and hope to see you on the next one. We are going to be talking about we are going to be diving into this topic one last time for part 3, and topic's going to be around maximizing the value, or is this just all added burden, right? So
Yep.
we'll
Yep.
be
Yep. So it's gonna be. We're gonna break down numbers on it, right? So
yes,
if we use 99213, 99214, what can we expect out of all this? What can we expect out of all these different things? And I'm gonna base it again around the GP because I'm not gonna do every specialist code. That shit's wild. Like it's gonna be your job as a specialist, but we
right,
can really map out, is the juice worth the squeeze?
yes. So again, guys, I appreciate your time and look forward to seeing you guys at the next one. As Jose mentioned, you guys will be receiving an email from us with the registration link and some other links as well. If you have any questions, concerns, please feel free to reach out to us anytime. We're here to help. So,
Thanks, guys.
Jose, thanks again, and we'll see you guys on the next one. Take care, guys.
Absolutely.
Bye.
Sunshine.